Okay, we'll go live.
Hi, Jen.
Hi, Nafisa.
How are you?
Good. How are you?
I'm all right. Thank you very much. How's
Good.
David and the family?
Very well, thank you. Yes.
That's great. So I think people are just finishing their dinner.
Nice.
Yeah.
What time is it there?
It's close to 8 p.m.
Oh, 8 p.m. Okay, yeah, because 1 p.m. here.
Yeah.
Good. And how's everybody your end?
Oh, we're all good. Thank you, Jen. We're all fine.
Good. Yeah, I'll just check out the, yeah, that's going to work. And tell me again, 45 minutes.
About that, plus minus. Yep. Yeah.
And then questions?
Yep, that's right. About 15 minutes or so.
Yeah, I'll let you post that.
All right. Thank you.
How many people have you got?
Right now, it's all of us here, 11. Yeah. People will come in slowly, I think.
Yeah. Good. And you're doing a series, yeah?
Yeah, not very many, but because we intend to continue this sort of lecture and discussion series. So yeah, so that's why it's called a series, yeah. But there will be different topics every time.
Mm-hmm.
I thought asking Asim to talk on statins. That would be interesting, I thought.
Mm.
But we'll see, we'll see.
Yep, or Malcolm Kendrick.
Oh yes, that's right. Of course, of course. How was PhD this year? How was it?
Yeah, it was good. We had it was bigger. We had more people because we were in a bigger venue, and it was excellent. So we looked after Georgia Eid. I don't know if you've come across her.
Yes. And I heard Ben was over too. Ben
Bickman and
Yep.
Sean Baker, and we're all going on Friday. We're all heading Saturday. Actually, we're all heading off to Keto Live in Switzerland.
Oh, okay.
Which is lovely.
How
You'll have to come. You'll have to come and do that one year because you meet some amazing people. Well, like all these things really, but Ben Bickman and Georgia are speaking there as well.
Oh, okay. So a lot of traveling for Ben.
Yeah, well, they both just stayed over in Europe actually. So
oh, okay. Yeah.
It's
sense.
Not so bad.
Makes sense.
Yeah. Yeah. They've just been doing other talks and bit of a holiday, I think.
Yeah, Sufyan and I always talk about going over either to PhD or to low carb USA is what we have been going for. Not have been going. I've been there a couple of times. Yeah.
Yeah, we went to Florida this January and it was fantastic.
Oh, okay.
We really enjoyed it. Sunshine.
A red light.
Rezai, although at the moment we're having a very weird run of sunshine and no rain. We've had already about 3 weeks of sunshine, and it's next 2 weeks look good. So
what's the temperature there?
It's actually warmer here than it is in Switzerland where we're going. So it's been in the mid-20s, which is pretty good for us, isn't it?
Good. Yeah, it is good.
Yeah. The next couple of weeks are looking really good. Yeah, very strange.
Let me see. It's 1 minute to 8. I saw Robert winning. I can't remember what he won the award for just recently. Yeah.
Butcher of the Year. Yeah,
Oh,
for the whole of the UK.
That's right. Yeah.
He's very happy. Yeah, he's very happy.
Looks happy. That's good.
Yeah. So he's just been open nearly 2 years, and yeah, so he's doing
so well.
It's doing really, really well. It's really been really well received up there in Kendal. When you come and see us, we'll take you up there.
All right. Okay. Sounds good. Sounds like a plan.
Yeah, definitely.
Dr. Huzaini?
Yes, Prof. Shall we start? Or
I think we should. It's 8 o'clock and people can join later. Yeah.
a few people have told me that they are joining via YouTube as well. So
okay.
yeah, not just here. All right. So let's start. Assalamualaikum warahmatullahi wabarakatuh, and a very good evening to everyone who has joined us today. It gives me great pleasure to introduce Professor Dr. Nafiza Muhammad Ismail, who will be the moderator for the night. She will be introducing our speaker for the webinar. And this webinar is co-hosted by Faculty of Medicine UiTM, as well as the Malaysian Society of Pharmacology and Physiology. So without further ado, I pass the screen over to Prof. Dr. Nafiza.
Thank you, Dr. Huzaimi. Well, it's great to be here, right? And this is the very first webinar series of the global lecture and discussion series abbreviated as GOALS. And I'd like also to say good evening to everyone and welcome everyone to this evening's talk. I think it's on food addiction, and I think this is it's a topic. I think it's been delayed. I would say that it's been delayed. I mean, it was. I think the whole world, not really Malaysia, the prevalence of obesity and chronic diseases related to food addiction has been growing for a long time. And so I googled food addiction, and according to WHO, they have loosely defined it as hedonic eating behavior involving consumption of highly palatable foods in large quantities and affects children and adults. And it's when they say it's highly palatable, I know they're talking about ultra processed food, but you can educate us on that, Jen. And I'm so happy to welcome my good friend, Dr. Jennifer Unwin, who is a consultant clinical health psychologist, and she's got food addiction deep in her passion. Jen was a past chair of the UK Association for Solution Focused Practice, and she was winner of the British Psychological Society Karen Allard Lifetime Achievement Award in Clinical Health Psychology. Dr. Jen Unwin has spent her professional life interested in the role of hope in chronic diseases and how it can be used to bring about behavior change. Her insights teamed up perfectly with a ever so lovely husband. Usually we say ever so lovely wife, but in this case, David is just as lovely. So with Dr. David Unwin's interest, it lines up, and it's really in sync what Jen, what you and David have been doing. You've teamed up perfectly with Dr. David Unwin's interest in bringing about drug-free type 2 diabetes remission. And for over 10 years, the Unwins have been running group sessions in primary care and they have helped many patients to achieve remission and have reduced or taken off medications under supervision, of course. Both doctors, Dr. David Unwin and Dr. Jennifer Unwin, they were both featured in a BBC TV documentary, and Jen, I was so excited to see that. And the documentary was The Truth About Carbs, that was seen or garnered 3.7 million viewers. Dr. Jen has also written a book, A Fork in the Road, which is a metaphor based on a literal expression for a deciding moment in life. I might add, Dr. David Unwin has always told me that the patients respond best when they are at the choice point, when they have to make a decision. It is to help people with food addiction. Dr. Jen's book, it is to help people with food addiction. And Jen is definitely an integral part of the team developing food addiction resources for the public health collaboration. And public health collaboration, for those who are new to public health collaboration, it is a joint venture between the health professionals and the public. They collaborate and they hold a yearly conference. And I'm very happy and so proud to have attended the very first PHC conference. And without further delay, I invite Dr. Jen Unwin to talk to us about food addiction.
Thank you so much for that lovely introduction, Nafisa. It's an absolute pleasure to be here and talk to you this evening. Thank you for giving up your evening to learn a little bit about food addiction. And I hope you agree at the end of the lecture that, as Nafisa says, we've been a bit delayed in recognizing this, but it's probably underlying the vast majority of our chronic long-term lifestyle diseases. And in fact, a paper came out very recently so recently that I haven't just included it in this lecture, but I can certainly forward it to Prof after the lecture, which showed that people with food addiction were 6 times more likely to be diagnosed with type 2 diabetes, just one of those conditions that we might be interested in. And I think we have to ask ourselves why there's increasing numbers. Really, we're having a terrible time in the UK with the amount of ultra-processed food that we're eating and the increasing numbers of people with these chronic and disabling lifestyle conditions. So let's get straight into it. I'm going to talk for about 40 to 45 minutes, and then I'll really be interested to hear people's questions on the topic. So this is what we're going to try and cover. What exactly is food addiction, how you might recognize it, how common do we think it might be in certain clinical groups, but also in the general population, in adults and young people, how you might screen for it or recognize it in your clinical practice, because it's highly likely that in every clinic this may be an underlying problem to some of the presenting issues that you're seeing. What treatment approaches might we think about? It's early days, obviously, in thinking about this. But obviously, my interest in coming from the background of working with the other Dr. Unwin on low carbohydrate diets for diabetes, and also there's just a logical reason for using low carbohydrate plans. We published at the end of last year a paper based on an audit of an intervention that I'd like to share the results with you, which were very pleasing at that stage, and then also point you to some further sort of resources and things that if you are interested and you want to find out more, or you just want to point patients in the right direction, if you suspect they may benefit from looking at their problems through this lens, then I shall do that as well. Okay, so really the best place to start is what do we think food addiction is? How we might spot it and how we might screen for it. So I'm just going to take you through the screening questions that we've been using, and then explain where they came from and how you might use this as well. So although there are some real commonalities, and we've already mentioned about ultra processed foods, and when the research has been done, it is nearly always ultra processed foods that people struggle with. Things like very sweet things like ice cream, donuts, chocolate, very, very typical. But also there are a lot of people who struggle with the more sort of processed savory foods, like we would call them crisps. I know the Americans call them chips, don't they? Things like that come in packets, or pizza, these kinds of foods, French fries, kinds of thing, burgers in buns and so on that you can buy. So we usually ask people to think about any foods or non-alcoholic drinks, because that's kind of a separate issue, that they struggle to control their intake of, especially once they've started to eat them, or the foods that preoccupy them a lot during the day, and they think about not eating and they think about eating and so on. So you might like to play along and see if there's any of those foods in your own life that once you have them, all bets are off. you really, you can't control it, or you think about them a lot. So having got those foods in your mind, or talk to your patient about, are there any particular foods that they really struggle to control their intake? And interestingly, in the UK, quite a few patients that we come across simply have a problem with bread. They eat a significant amount of bread every day and really struggle to control their intake of it. So I don't know how, in terms of in Malaysia, how common that might be, or certain kinds of breads that people might struggle with. So have you ever, and we're going to play along, and it's simply yes or no, have you ever had such a strong desire or sense of compulsion at the thought of eating those foods that you could not resist the urge to eat them? So for example, if you know something's in the cupboard, you're trying not to eat it because you promised yourself you wouldn't do that, but you get in from work, you know it's there, you try and resist for a while, but then you end up eating it, or going in the freezer to get some ice cream. Or sometimes people describe, even they're at home, it might be sort of reasonably late at night, but they have such a strong compulsion that they end up going to the shop, driving to the shop or to the garage, so that they can get the particular food that they're craving for. So that's a yes or no to that one. Have you ever noticed that you need to use increasing amounts of these foods to get the same effect compared to when you started? So this might describe that, maybe you used to have a little chocolate bar at the coffee break, but then you find you're having, one at coffee break, one at tea break, and another couple in the evening. Or I've spoken to people who say, they start on one little individual bar, and they end up buying a family bar eventually, or 2 family bars. So the amounts are increasing. Number 3, have you ever noticed a growing neglect towards planning of activities because you're too tired, preoccupied, or sick due to overeating these foods? So we often find people, their sort of sphere of activities is narrowing because they're getting so preoccupied with food, or maybe they're upset because they're overweight, so they don't want to take part in things, or they're just so preoccupied with food that the world is kind of narrowing around them, if you like, to become focused on that. And I'll explain why these things happen later on in the lecture. Next one, have you ever used more of these foods than you intended on more than one occasion? This gets at the idea where, people say to us, well, I bought the packet of cakes or biscuits, telling myself it was for the grandchildren, and then I thought, well, I'll just have one before the grandchildren come with my cup of tea, and they end up eating the whole packet. So telling yourself you're going to have a small amount, but then losing control of the amount. And then this one is, have you experienced at least 2 of the following withdrawal symptoms when you try and cut down or stop using these foods? So usually people have tried to cut down, they know they're not good for them, they've tried to cut them out, and they may experience headaches, nausea, vomiting, anxiety, low mood, irritation, shakiness, sweating, palpitations, disrupted breathing, gastrointestinal problems, sleep disturbances, etc. So have you ever experienced withdrawal symptoms when you try and cut down on these foods? I know for sure that the first time I quit sugar cold turkey, I think I had nearly all of those, most of those over the first few days. It's quite tough physically in the first few days. Okay, next one. Have you continued to use these foods despite you or someone else believing that your memory, concentration challenges, anxiety, mood swings, depression, panic attacks, or other physical or mental health problems, for example, type 2 diabetes, were likely due to your use of these foods? So have you continued to use despite knowing it's doing you harm, or someone else believing it's doing you harm? Okay, so there's just those 6 questions, and 3 or more yeses would indicate some problem with a, in quotes, substance use disorder. So what we've done here is we've just taken the criteria for substance use disorder, which you would generally apply to alcohol or other drugs, according to the World Health Organization International Classification of Diseases, and we've reworded it to make it apply to food. And I'm sure you'll agree, so that those are the 6 criteria for substance use generally, and 3 or more is the cutoff for some sort of indicating some sort of a problem. It's obviously not a diagnosis, it's not a diagnostic interview, but I'm sure you can see either in yourselves or potentially in your patients, or maybe a member of the family, that those questions absolutely apply to some of us in terms of our eating behavior. So we've made a nice way for you to remember these symptoms in the clinic, and we've called it CRAVED. I work very closely with a fantastic nutritionist called Heidi Yaver. I trained with her to work with patients with food addiction from Bitten Johnson, who's the sort of probably the world's most well-known clinician in this space that runs training courses. So we came up with this acronym CRAVED, which picks up those 6 criteria. So it goes the compulsion, the powerful urge to consume more. Reaching for more gets at this idea of increasing tolerance, which we all completely understand from alcohol. You know, if you have 1 drink every night, soon you don't kind of get much effect from that, so you might end up having 2 drinks every night, and then half a bottle, and then so on, to sort of to get the same effect. A is activities neglected. V is volume, having more than you intended. E is for exclusion, the idea that if you try and eliminate the substances, you get withdrawal symptoms. And D is for damage, which I kind of feel is that if you're looking for one symptom to sort of rule them all, then it would be continued use despite awareness of damage. Or as David and I say, why do clever people do stupid stuff? Most people know, don't they, that smoking's bad for them, that, you know, excessive alcohol is bad for them, and that eating a diet very high in ultra processed food, there's not many people now that don't know that that's not good for their health, but you know, they really struggle to stop. And that for me is the defining criteria really for thinking about maybe it would be an addiction. Yeah, so we've also, you can't really see this, I know it's very small, but it was just to show you that we have developed a sort of a 1-page screening tool out of those questions. And if anyone is interested in using that in their clinic, please do get in touch with. I'm not sure I understand. Sorry, my watch is talking to me. Please do get in touch, because we're happy to collaborate with people who want to sort of try and work out if it's helpful in the clinic. We've got a few clinicians using it already as a sort of quick screen to see if it might be useful to explore these ideas further with their patients. So, right, so we're thinking about these eating problems then as a form of addiction. And of course, there are many forms of addiction, but what we do think is, and what most addiction specialists think, is that addiction is one disease with many ways that it might express itself. So according to the American Society of Addiction Medicine, addiction is a treatable chronic medical disease involving complex interactions between brain circuits, genetics. There's definitely seems to be a sort of factor where this runs in families. I often talk to maybe women with food addiction who had dads who had problems with alcohol. So, you know, there does seem to be sort of family factor, the environment, and an individual's life experiences. So we do think that sometimes early trauma can actually also affect people's likelihood to get more addicted to these substances. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. And I think that's a really lovely summary there of what we're talking about. So what might be going on then? How is it? Because people say, well, we have to eat, you know, we have to eat. That's how can food be addictive? Well, we know that, for example, gambling is recognized as an addiction, and there isn't any substance there at all, but we know that gambling can be strongly addictive in sort of behavioral terms. So one of the things that we know is going on is that when we ingest some sugar or highly processed refined carbohydrates, what we get is many things going on in the body. We know about insulin going up to clear sugar from the bloodstream, for example. But what we forget is that actually we get very high levels of dopamine and serotonin in the brain. And we think that probably this is to some extent an evolutionary thing. So that in the autumn, when it was a good idea that we ate absolutely as much carbohydrate as we could get our hands on, or any food we could get our hands on to get through the winter, so that these highly palatable foods give us a sort of unnatural boost of dopamine and serotonin in the brain. When we have high insulin, tryptophan can preferentially get into the brain, and tryptophan is a precursor of serotonin, so that's the reason we get more serotonin. Dopamine's the kind of motivation neurotransmitter, and really it means we're just very motivated to repeat any behavior that gives us a boost in dopamine. So we're very motivated to repeat the behavior of whichever food we've ingested that's given us that boost. And we will really pay attention to any cues that were around at the time. And this is how the sort of fast food and confectionery industry get us. So, for example, let's take an example of the McDonald's yellow and red. You know, that becomes associated with the dopamine. And so when we see that, we're driving along and we see that there's a drive-through there, and we see the red and the yellow, then, you know, we're more likely to be drawn and triggered to go there. So we ingest sugar and carbohydrate, we get these dopamine, serotonin highs, and like everything in nature and in the body is always trying to balance out what's going on. The brain doesn't really like these super dopamine and serotonin highs, and it thinks, well, there's loads of dopamine and serotonin around, so the best thing to do is to knock out a few brain receptors. And I hope you can see that knocking out a few of your dopamine and serotonin receptors is not a great idea, because that's going to lead to low mood generally and lack of motivation. And we've seen plenty of research linking high sugar diets with depression and anxiety, for example. That's just a well-known finding now. So we get low mood, and because we're in a low mood, we're going to be craving something that's going to improve that mood reliably. And of course, we've learned from experience that sugar and carbohydrate, if we have those, that's going to improve our mood temporarily. So we have that's what develops the cravings and these compulsions to eat those foods, and round this merry circle we go, digging ourselves into a worse and worse place, both physically and psychologically. And certain parts of the brain are sort of become wired, rewired because of the, you know, these responses. So the preoccupation and the anticipation of eating those foods, the thinking about those foods and the planning how you're going to get them, is obviously in the sort of intelligent prefrontal cortex part of the brain. So yeah, or maybe not so intelligent in this case, but yeah, that we're very clever at planning and thinking about how to get these foods. And of course, it's super easy to get these foods. We don't have to actually do a lot of planning or be very clever, because they're on every corner and in every shop. And then we have this sort of intoxication phase where we're eating the foods, and it's you know, we're really getting that high, but then we get the withdrawal symptoms and the withdrawal effects. So there's a couple of twins in the UK that are doctors called the Van Tulleken twins, and they've just one of them's just brought out a book called Ultra Processed People. I'm not sure whether you guys can get it over there, but they were very interested in this topic because one twin is a bit of a food addict, and the other really wasn't, and he wanted to understand why he couldn't help his brother. So he, the one who wasn't addicted, spent a month eating ultra processed food, and they did brain scans on him. It was so fascinating that the picture on the right there shows all the new connections that the brain was making, as you can see, between the cerebellum, the reward center, and the frontal lobes. And interestingly, after the end of 6 months of when he'd gone back to his real food diet, those connections were still there. They hadn't been sort of unlearned, if you like. So that's the scary thing, is that when we rewire our brains to crave ultra processed food, that looks like it's at least semi-permanent, if not permanent. And of course, young children, we don't let them have nicotine, alcohol, caffeine or other drugs, but we really do let them have sugar. And it's pretty scary to think that their brains are maybe being wired up for life, being caught eating these foods and then craving these foods. Of course, food is even marketed as a drug now. We've sort of we've just got so deep into this that, you know, it's a sugar fix, you know, it's kind of drug language. And also here, these chocolate bars being marketed like they're going to cure your withdrawal symptoms, they're going to cure your fuzzy head and your sluggishness and your grumpiness. And yeah, it's a concern. So if we Google food addiction, like Nafisa did, you get all these billions of millions of results. So even though officially the World Health Organization, neither the World Health Organization or the American Psychiatric Association in America recognize food addiction as a medical condition or something that should be recognized and treated, the public are very, very interested. And also there's been increasing numbers of papers. Every year there's more and more papers being published on this topic of food addiction, and there's a push now to actually call it ultra processed food addiction, because it's not any old food that we get addicted to, it is these ultra processed foods. In terms of prevalence then, there was a big meta-analysis in 2021 using the Yale Food Addiction Scale, which is a research tool based on the American criteria for substance use disorder. And they found in all the studies they looked at about a 20% overall prevalence, but much higher in certain clinical groups such as binge eating disorder. And there you see that paper from 2016 showing a really big overlap with a bulimia sample, 96%, which is incredible. Possibly up to 70% prevalence in patients with type 2 diabetes. And probably about this sort of 8, 9, 10% in the broad general population, although there is some idea that the YFAS tends to underdiagnose. The really worrying thing is this trend for the prevalence to be higher in children and adolescents, and that's because they've been brought up all their lives in this ultra-processed food environment, and up to 20% of overweight children, for example. So what does that equate to? I've just done the numbers for the UK, but you guys would be able to do the same for your own population. So if we take the really conservative estimate of 8%, that equates to 4.3 million adults in the UK, which is super scary for a condition that there's no official treatment for or recognition. In the UK, you can't get treatment for. So is food addiction recognised as a medical condition? No is the answer. Some of us are campaigning for that, and if anybody gets fired up after this and wants to know more about that project, they can get in touch with me. So what do we do? So because it's an addiction, and we know that the treatment for addiction is usually abstinence, and that's been well proven in drug addiction and alcohol addiction. What should we be abstaining from? Obviously, ultra-processed food and refined sugars and flours in particular. So this is a super paper, just expounding that as an idea, really. But very little research has been done. I'm in a group of food addiction professionals, and we asked them how many of them use low carbohydrate or keto real food plans, and 20 out of 25 who replied said they were recommending low carbohydrate food plans. So we decided to kind of look at that. So the first way that I looked at that was there's a website called diabetes.co.uk here in the UK, and they offer low carbohydrate online programs for patients, and these are general type 2 patients, they weren't particularly selected to have sugar addiction. But when we asked them, if you look at the before columns there, 25% of the patients screened before they did the program seemed to screen positive for having food addiction. And when they'd done 180 days or more of the low carbohydrate program, and we asked them again, then 7.88% were screened positive for food addiction. So it looks like for patients with type 2 diabetes, where about a quarter of them was screening positive for food addiction, that a low carbohydrate program was improving their food addiction symptoms. And that was done using the YFAS, that research and instrument, the Yale Food Addiction Scale. So what we decided to do was an audit of 3 programs that were very similar. So myself and Heidi in the UK, and a North American group and a Swedish group. And what we did was we just recruited sort of through social media. We said, do you think you're a food addict? Would you like to come and join an online group that we were sort of running anyway? We just wanted to sort of do a proper audit of what we were doing. And so we have recruited more patients than us. This is just the first paper that we published on the initial outcomes. So participants were self-diagnosed with food addiction, but we did obviously screen them once we'd got them on board, and they all had a 10 to 14 week online intervention where we explained the kind of things I've been explaining here, the biochemistry of the brain, how it's an addiction. We did a screening with them. We talked about low carbohydrate abstinent, in quotes, abstinent food plans, and then work with them on relapse prevention and recovery protection, which is obviously essential in addiction. You can't just sort of give everyone the knowledge and send them off. You have to really support them, a little bit like the Alcoholics Anonymous model, where you're supporting people long term. So they were going to get 2 years support, and the first group are just coming up to 2 years now, so we'll have some more data soon. But we got some super results straight after the group, which I'm going to show you now. So the craved score, so you remember there were 6 questions, and you can see from the dark green lines are patients who improved between the start and the finish, and it goes UK on the left, North America in the middle, and Sweden on the right. And you can see very similar results across all the 3 programs. And you can see at the bottom there that all of the results were significant. And if we sort of pool the results, this is the diamond here at the bottom, shows that the pooled results also show a significant reduction in food addiction scores at first follow-up. We use the Yale Food Addiction Scale because that's the one that's been most validated. And again, you can see the dark green line showing people who improved on the Yale Food Addiction Score, and again, significant improvement when you pool those results. Some non-improvement, and some scores getting a little bit worse, and we're going to be looking at the factors that affect outcome in our next paper, hopefully. We also looked at mental well-being. There's a lovely scale called the Warwick-Edinburgh Mental Wellbeing Scale, which is quite a brief scale, and it's been used a lot in the UK to look at mental well-being outcomes of various programs. And we were really thrilled to see that at follow-up, people are feeling significantly better in terms of their mental well-being. And that is what we'd expect, because they're eating fewer of these sugars and carbohydrates that are sort of affecting their brain chemistry, and presumably they feel, you know, more in control of their lives, and you know, better physically generally as well. So we were really pleased with that. So mental well-being improving. We weren't particularly interested in weight, because really what you're trying to do on the addiction side of things is to remove the addictive foods, but to really establish a sort of regular good eating pattern of real whole foods. But we did actually get significant weight loss across the groups, not massive amounts, but yeah, most people did lose a little bit of weight. We're kind of pleased by that, and obviously in the long run you would expect that. About 11% of people with food addiction are actually start off as either normal or underweight. So when you're in your clinics and you're wondering if someone might be a food addict, they aren't necessarily overweight. They may be normal or underweight. Okay, so sort of rounding it off a bit now, just to remind people that yes, I have written this little book. All the profits go to Public Health Collaboration, which is a charity. So the book's called Fork in the Road, and it's available on Amazon, and it really goes through all the things that I've talked about, and it gives people the food lists and some recipes and more resources, but it, you know, it talks about the science as well. And David's actually written that chapter that you can see there on the right, where starch's glucose molecules holding hands is what David wrote for us for the book. We're really busy now as well in the Public Health Collaboration. We're about to launch some courses for professionals. So there'll be 3 levels of course, an introductory course, a sort of mid-level course, and then one where you can actually train to work with people with food addiction. The introductory course is a bit like the information I've given you today, you know, maybe to help you recognize food addiction in the clinic, and then maybe, you know, what you might say to people or where you might point people. So it's that sort of level of training. And we'll also be running courses for the general public that they can either have a coached course, so they can sign up at a certain time and get, we'll be talking them through the information, and then they'll be on a call with other people, or there'll be one where they can just watch a recording if that's what they prefer. And then we'll be running support groups 3 or 4 times a week that they can join for us. These are all for a small cost, but because it's all online, you know, you could absolutely refer your patients to us if because we'll be having classes at different times of day. There probably would one that would work with your time change. So if you're interested, the best way is to register your interest with that QR code. So if you just open your phone to the camera and then click, there'll be a form to fill out, and you can say what aspects of what we're doing you'd like to be informed about, and we'll send you that information as soon as we launch any of the courses. You'll get informed for that. So that will be people's best resource going forwards, would be to refer people to our little groups. So in conclusion then, yeah, a proportion, possibly a growing proportion of the population will have addictive relationship with certain foods, tending to be ultra processed foods, which are just everywhere now. So it's very hard for people to avoid, and often they feel very isolated and ashamed because they can't control their behavior. And really one of the big messages that you can give your patients is that it's not their fault. It's that our brain responds to those foods in a certain way and sort of starts controlling our behavior, if you like. You'll find a higher prevalence in certain clinical groups, so that those of you that do work with type 2 diabetes patients or overweight patients, or eating disorders even, you're going to find higher rates than in the general population, and maybe up to 70% of people with type 2 diabetes. I think really all clinicians should, you know the symptoms and be able to sort of screen, perhaps take it into account in how they're talking to people and how they're planning somebody's treatment. And once you know somebody has a probable food addiction problem, I mean, some people are so relieved when you just raise the issue with them. They're so glad that somebody's sort of spoken to them about it. And then, you know, you're going to give that person different advice from somebody who hasn't got that problem. So clearly, from what I've said, moderation is never possible for somebody who's got an established food addiction problem. If they've been addicted to like let's say bread or ice cream, they've lost control of their relationship with that food, and they won't be able to moderate that in the future. So counseling abstinence is the better advice. Of course, it's a simple piece of advice. It's not easy for them to follow it necessarily, and that's why it can be so good to be treated in a group setting, because then they don't feel isolated. They don't feel like they're the only person with this problem. They can, you know, share their stories with other people who completely identify and completely share that experience, and will support them going forwards. And in my view, it's nearly always going to be the case to have some access to long-term support. So it does seem like low carbohydrate real food approaches, you know, although, you know, we can't say that that's proven, but I would say it makes sense in terms of the a sort of addiction model. It makes sense to be abstinent from the foods that you can't moderate, and generally low carbohydrate real foods people don't have so much of a problem with. Some people still overeat, and particularly when they start out, they're still overeating foods, but that does seem to settle down over time. Ongoing support's vital, as I've already said. And yeah, I think if we can get the condition recognized by the World Health Organization or the American Psychiatric Association, once one goes, I think the other would go. And then research would be funded, treatments would be funded. But of course, there's lots of reasons why they're not going to recognize it. There's a lot of vested interests, just as there were when we started to recognize that cigarettes were harmful to health. It took some time for that to filter down to public health interventions. We know that those public health interventions did work in smoking, so I think we've got reason to be optimistic, and I really hope that in my lifetime we can see this condition recognized, and I think that would help millions of people with their mental and physical health. So I think that's it. Yeah, there's some references, and I hope that's been of interest. I shall stop sharing my screen now, and perhaps Prof can tell me if we've got any questions, or if she has any questions.
Yeah, we have a question, Jen. Thank you. First of all, thank you. That was really interesting. Very short, concise. You hit the nail right on the head. Before I go to the question, I like the part where you said it can't be done in moderation, because if somebody comes to the clinic and say, I smoke about 40 cigarettes a day, try smoking just 20. That will do. That will be good. No, it doesn't work that way. Yeah. And
yes, just have one whiskey on a Friday. It's never going to turn out well, is it? We understand, once we understand it's an addiction, and it becomes laughable that we say, you could moderate, like to say to me, because I didn't really say, did I? But I totally identify as being a food addict, and if somebody said to me, well, just have a bowl of ice cream that's this big, just have this bowl of ice cream. I mean, it's just not possible.
Yeah, and when there's a scientific explanation to that, as you mentioned, the reward pathway is stimulated, and you want more of it. And sugar is also stimulating. Also, is known to stimulate the opioid receptors.
Yes.
Yeah,
yes. And I didn't really go into that, but yes, definitely endorphins, and also oxytocin, which is the kind of it's kind of closeness hormone, isn't it? It's a very interesting one, oxytocin. And I talk about in the book, because you're taking that away from people when you say don't eat those foods. You need to think how they're going to get that in their lives. Dopamine, oxytocin, serotonin, endorphins, and so I call that dose, getting your daily dose. And what are people going to do to get their daily dose of those things without turning to the foods? So things like just going for a walk, actually, getting some exercise, really good for it. Dopamine, endorphins, if you're outside in the daylight, serotonin. And if you maybe take your dog or your wife with you, you get oxytocin as well, So just a daily walk can be a real help to people's mental health.
There's a question which I will read out. Someone wants to know, or Akra bin Shah has asked, how does the research community operationally define ultra-processed foods?
Yeah, so there's these NOVA classification, isn't there, of foods, and I think you're sort of largely thinking about the NOVA 4 foods, which are, I can't remember the exact definition, but they've got multiple ingredients that made in a factory. They're very things like a frozen pizza or something like that that's got several kind of ingredients that you would never recognize or have in your kitchen. They'd sound more like chemicals than ingredients.
And we won't eat if the chemicals were not on the chip, it will, if it's just in the spoon or plate, we won't be putting it in our mouth, right?
Yeah, for sure.
I've got so many questions, but I can ask you some of the time. To give a chance to anyone, you can just open your mic and go straight ahead and ask Dr. Jen. Anybody? Anyone?
Anything in the chat?
Sorry, Prof.
Yeah.
There's a question over in YouTube Live.
Okay, good.
Shall I read it out? Yeah.
Yes, go ahead. Go ahead.
Yeah. So this participant asked, should we name this issue as sugar addiction instead of food addiction? Food sounds more general.
Yeah. So I mean, this is a big debate in the space. Interesting, a lot of the research papers have been published under food addiction. There are certain people that say really the addictive substance is probably going to turn out to be sugar, glucose. But I think there's going to be an argument for actually calling it ultra processed food addiction, because there's probably the most evidence around that, and that will, I think, at least get us in, and at least it sort of points the finger where it needs to be pointed. So the idea of ultra processed food, now that may still be a little bit too broad for some tastes, because they'll say, at least with alcohol, we know it's ethanol that's the addictive, and we know it's nicotine in cigarettes, we know it's caffeine, we know the chemical. But we've perhaps not got enough research to absolutely say it is the sugar or the glucose. So at the moment, we're doing a sort of consensus process with a lot of researchers and clinicians in this space, and we're going to try and get to some consensus about what to call it. And early results are looking like it might end up being ultra processed food addiction, just as, you know, people in this space working, you know, feel that might be the most appropriate name at the moment. But yeah, thanks for the question. I think probably food addiction is too broad, and is why people have said, well, that can't exist because we have to eat. So yeah, because you wouldn't call smoking breathing addiction, would you? Yeah.
Right. There's a question from Prof. Amir. He's asked, is an emotional eating related to food addiction?
Yeah. So it would be quite hard to sort of distinguish the two. People with food addiction would definitely say it's, you know, there's a proportion of people who would say it's definitely worse when they're in an emotional state. Or we talk about HALT, which stands for hungry, angry, lonely, or tired. And those are often times when people find it really hard to not eat these foods, because obviously, as we've said, it's a kind of self-medicating, isn't it? So self-medicating if you're obviously hungry, but you know, we don't have to eat donuts, do we, when we're hungry? We could eat a nice piece of chicken or something. Hungry, angry, lonely, and tired. And also links into this issue of, we do know that trauma can be either in childhood or adulthood. I've actually seen one or two patients who didn't seem to have a food addiction problem, and they've had a trauma as adults, or they've got a chronic pain or something like that, and they've turned to food as a comfort and sort of developed a food addiction later on. So we do know that trauma can be a factor. And again, it's the only psychoactive substance that children have access to. So if children are in a difficult emotional, or you know, there's trouble at home when they're growing up, it is something that they have access to sort of self-medicate. So yeah, I think there's very strong links between emotional eating and food addiction.
Oh, thanks for that, Jen. Huzaimi, Dr. Huzaimi, any more questions from YouTube?
At the moment, Yeah, at the moment we only have that one just now.
Okay, I'll just have one question, a couple really, but I'll just ask this one. Do you find that your patients who get off the addiction have very good family support? And having said that, family support we know is so important in whatever kinds of addiction. But when we talk
Yes.
about substances of abuse and we're talking about drug addiction, then we send them to rehab, or there's a place where they can go and not have, hopefully not have access to drugs. And if it's alcohol addiction, alcohol doesn't need to be in the house, but food is so different. I mean, you want to get off the addiction, but there are other people so how would you go about circumventing that?
Yeah, you've absolutely nailed that point. It's really hard for people if they're doing it on their own in the house and there's other people. It's not impossible, and we talk about various strategies like, you know, having your own cupboard. Don't go if you having a conversation with people in the house that if they still want to have those foods, can they keep them out of sight? Can they buy them themselves? You know, can you have your own space in the fridge? So trying to do some environmental controls, but yeah, it's super hard. It's much easier. We tend to find either people live on their own or they live with someone who's going to kind of support them and do it with them. That's it's definitely the case. And like you say, you know, it's everywhere, so it does require people to really, you know, change the lifestyle. And this is why we need the, like you say, the support. You know, they need to be in groups of other people with the same going through the experiences. And people do slip up as they would in any other addiction, but we try and treat that as a sort of learning experience, you know, like okay, you know, you went out for coffee with your friend and you ended up having a piece of cake. What would you do differently next time? Or you were on the aeroplane and there was nothing else to eat and you ended up having the you know, the aeroplane meal. What would you do differently next time? So it's, you know, it's always about planning ahead, you know, thinking where there might be problems, and then forgiving ourselves if we do have a slip up. Just get right back on the horse and try again and try and learn from what's happened. But yeah, it's not it's probably going to be. And also the other thing is that obviously we're in a society of sugar pushers as well. So at work there's always somebody who's made an amazing cake, or, you know, says it's your birthday, so you should definitely, you know, just this once won't harm, because people don't understand always that, you know, somebody might have an addiction problem. So it's really difficult socially to navigate. Not impossible, but can be very tricky. So yeah, it's not an easy thing to do, but there are people increasingly doing it, you know, and you know, are there to sort of share their experience and cheer everybody on. There's quite a few Facebook groups now. There's No Sugar, I'm Sweet Enough, and then Bitten Johnson's one is Sugar Bomb in Your Brain. So there's quite a few really good Facebook groups now encouraging people. Yeah.
Any other questions? We have about 30 people. Sponsors from outside UTM, of course. Sorry, what is it, Huzaimi?
It's related to the food bank form. Yeah,
all
sorry.
Right, okay, yeah, it's all right. And the thing you said about people having vested interest, I like I was really going to ask you to talk on sugar addictions. Call a spade, call it what it is. It's sugar addiction. But as you say, there's too many people with vested interest, and it's sort of a crime if you call it sugar addiction. Their vested interest is making a lot of other people sick, and just like was this the John Yatkin? Was it John Yatkin?
Yeah. Yes, yeah. all those decades ago.
Yeah.
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 It's really sad. And I don't know about over there, but over here, sugar production is actually subsidized by the government. You know, growing sugar beet is actually a subsidized. I mean, it's crazy. It's crazy.
Yeah.
Hmm.
So, all right. Any more questions? Any other questions? I mean, any other questions, Huzaini?
Just checking the YouTube just now. No more questions.
All right. So I guess
Yeah.
people have got a lot to digest, Jen, because it's a topic where people know of it, but it's not much talked about. And as you correctly said, if it's a diagnosis, then it will make everyone sit up.
Yeah.
Or most people.
Sure.
Yeah, I've got a problem.
Yeah.
And to admit they have a problem. Yeah.
Yeah, and I think in the meantime, because that might not happen soon, like it didn't with cigarettes, that just the more we talk about it and sort of acknowledge it as a condition generally in society, I think that's going to help. It's going to help people.
All right, Jen, it's close to 9. That leaves me to thank you, and I'll pass it back to Dr. Huzaini.
Thank you, Prof. Naviza, and thank you, Dr. Unwin, for the presentation. That's all the time we have tonight. Stay tuned though for more topics to be covered by this Goals series of webinars. If you are interested to get first-hand notification of the future webinars in the feedback form, please leave your email address there. And just a reminder again that the feedback form is linked to your certificate of attendance. So you fill in the feedback, you get your certificate. Simple as that. Thank you again, everyone, and have a lovely night and have a lovely day, Dr. Unwin, for you. Thank you.
Thank you.
Assalamualaikum warahmatullahi, and a very good night. Sorry.
Yeah, welcome salam. And send my love to the family, Jen.
Thank you.
Bye.
I will do. Bye-bye.
Bye.